Hi, okay, so today we're going to focus on ABG training, and I'm just going to get started with the PowerPoint, and hopefully this will work. My first time using my iPad trying to use an interactive whiteboard. So basically we're going to describe and demonstrate nursing assessments related to acid-base imbalances, and we're going to talk about a lot of different kinds of patients and a lot of different types of acid-base imbalances. So the first thing we look at is respiratory. We have respiratory acidosis and respiratory alkalosis. Respiratory acidosis will include patients like your COPDers. Basically, COPDers have a chronic lung limitation and they're not able to breathe out long enough. That's why we teach them pursed lip breathing to go and really focus on blowing off the CO2 because they are CO2 retainers. That's why they're in respiratory acidosis. Anybody with a sedative or barbiturate overdose, same diff. Think back to Nursing 350 when you learned about pain administration, you learned about morphine. What was your big concern there, right? That your patient would eventually have a decreased respiratory rate. So they have a decreased respiratory rate in an overdose situation. They're not able to blow off the CO2, so they're in respiratory acidosis. Obese clients, because their morbidly obese clients have trouble operating their diaphragm and they breathe shallow, but also because morbidly obese clients typically have sleep apnea. So they have periods at night when they are apneic or don't breathe, and so they're retaining CO2. Also, anybody with a respiratory muscle weakness syndrome like Guillain-Barré would definitively not be able to breathe out all the CO2, so they would be a CO2 retainer. Patients with a respiratory alkalosis are patients who are hyperventilating. So they're breathing off too much CO2. So they're, so one time in my ER, I had a cocaine, somebody who came in who had snorted massive amounts of cocaine and he was hyperventilating. And so he was in a respiratory alkalosis. Okay, then we move into metabolic. So metabolically, the same thing. We can have a metabolic acidosis or a metabolic alkalosis. So metabolic acidosis is going to be your patients who are in DKA. Think diabetic ketoacidosis. It's right in the word. So they have too much ketones and then they're acidotic. So metabolic acidosis. Also patients who have sepsis. They basically build up lactate from having their body go into anaerobic metabolism. So at the very bottom where it says shock or any other prolonged lack of O2, same thing. Your body goes into anaerobic metabolism and the byproduct of that is lactate, leading to a lactic acidosis. Kidney failure patients, patients with renal disease will have a renal tubular acidosis. They don't get rid of hydrogen ions enough, so they build them up and makes their body acidic. And patients with liver failure. All right, metabolic alkalosis. So this is losing too many hydrogen ions. So basically, if we're vomiting or if we have an NG tube and we're suctioning, it's the same as vomiting. Or if patients have a potassium deficiency. So why a potassium deficiency? Well, basically because the body's trying to compensate for the potassium deficiency and force some potassium out of the cells. So the hydrogen ions that are normally reside in and around the cells move in to force potassium out, and it results in a basic metabolic alkalosis. Also, anybody who intakes sodium bicarb. So those are patients who are intaking too many Tums. All right, so next we're going to learn how to analyze blood gases to include various levels of compensation. So first we kind of have to talk about compensation. So if the primary disorder is respiratory, then the kidneys will kick in to compensate. And if the primary disorder is the kidneys, then the lungs will kick in to compensate. Now, one key point here, the lungs can compensate right away. Okay, so a patient who's in DKA will automatically start to breathe deep, rapid respirations. We call those Kussmaul respirations to try to get rid of the CO2. But patients with a primary respiratory disorder, it will take a lot longer, like maybe 1, 2, 3 days for the kidneys to kick in to compensate. So that's just something to keep in the back of your mind as we start to look at cases and try to guess whether there's compensation. So here's your normal blood gas values. pH is 7.35 to 7.45. PaCO2 is 35 to 45. Bicarb 22 to 26. And your PaO2 is 80 to 100, and SpO2 is 95%, greater than 95%. So what's the difference between PaO2 and SpO2? Well, SpO2 is gotten when you put the little pulse ox on the finger, and PaO2 is the reading when we do a blood gas and we pull arterial blood out to do the reading. So there is some difference in the oxygen saturation between those two readings. All right, so moving forward. Now, we're going to start to learn to analyze an ABG. So I think there's like a 5-step method that I'm going to teach you to how to analyze the ABG. And it works really great. It should work every single time for you. And we start with step 1, analyzing the pH. So right now I'm going to move to I'm going to stop sharing here, and I'm going to do a new share to my iPad so that I can draw this out for you. All right, so let me just put my screen mirroring on. Should just take 1 second, and then you should be able to see my whiteboard. All right, let me get rid of that notification there in the bottom of the screen, and we should be able to see it. So what I like to do with ABGs is to write them out. So I start with pH, and I know that pH is 7.35 to 7.45. And the other thing that I know is that in the middle there's this magic number of 7.40. In between 7.35 and 7.45 is 7.40. Now I'll teach you what that's about later. Not important to know it now. Next we have our PaCO2. Now normally, remember I said that the norms are 35 to 45, but the fact is they're kind of opposite, okay? So what I do to make things easier is I make it 45 to 35. All right, so basically what I'm doing is I'm setting it up so that anything that resides on this side is going to be acid. And anything that resides on this side is going to be alkaline. All right. So next we have our bicarb, HCl3, and that is 22 to 26. And then we'll always want to be looking at our PaO2. Okay, and remember that that's, what did it say, 80 to 100? All right, so this is how I draw it out. So I'm just going to give you a second to go ahead and draw it out just like this, because all of the things that we're going to do from now on, we're going to use this little drawing. All right, I'm going to go back to my PowerPoint now. And yeah, 80 to 100, okay. All right, so remember how we said anything on the low side is acidic and anything on the high side is alkalytic. So in that PowerPoint drawing that we just had, and I can't go between screens with that, so I'm sorry, I have to do this every time, and then I probably have to like re-screen share probably, yeah, every time. All right, so that's a pain, but that's just what we're gonna have to do. All right, so this is our screen again. So it says everything on the low side is acidotic and everything on the high side is alkalytic. Okay, so everything on the left, acid, everything on the right, alkaline. So the very first thing we're going to do is we're going to analyze step 1, our pH. Okay, so now we're moving into step 2. All right, so step 2 is that we're going to analyze the CO2. So again, we flipped it around so that, because here, everything on the low side is alkalimic and everything on the high side is acidic. So that's why we flipped it. So once again, I'm going to show you that just so you can see that that's the way we did it. All right, so everything on the high side is acidotic. So that's why we did this. That's exactly why we did this flip. Okay, so everything on the high side is acid and everything on the low side is alkaline. Okay, all right. Next, wait, I think I missed a slide, sorry. Next, we're gonna analyze the bicarb. So again, anything on the low side is acidotic, anything on the high side is alkalotic, okay? All right, here we move on. Step 4. This is where we match the pH with either the CO2 or the PaCO2 or the bicarb, the HCO3. And whatever matches is the primary imbalance. So what do I mean by match? Well, it's in the column. So anything on, if it matches on the left, if you have a pH on the left and a bicarb on the left, then you know that you have a metabolic acidosis. If you have a respiratory on the left and a pH on the left, then you know you have a respiratory acidosis. And we're going to do a whole bunch of practice so that you can get what I mean by this. Next, we look for the value that goes in the opposite direction of the pH. So remember how we just said if we had a PaCO2 on the left and a pH on the left, if we had a respiratory and a pH on the left, that we had a respiratory acidosis. So if we have then the bicarb is on the right, if it's in the right-hand column, then we have compensation. Okay, if there's nothing there, if the bicarb is normal, then we don't have compensation. But if it's over here, then we have compensation. All right, and we're going to do a bunch of practice, so hang in there. All right, so let's do the first practice one. So I'm going to just take these figures over to my iPad. We want the pH to be 7.49 and the PaCO2 to be 40, and the bicarb will be 29. So I'm just going to draw these out on my iPad, and then we'll do that for a 5-step method. All right, so let me just share my iPad. All right, so here's our figures, and we had a pH of 7.49. So I'm just going to draw that over here. 7.49 is our pH. And we had a PaCO2 of 40. All right, so that's kind of right in between here, between 35 and 45. So there's our PaCO2 is 40. And our bicarb is 29. So that's over here, 29. So as you can see, this is our match right here. Okay, so we have two things in the alkaline column. We have bicarb, which is metabolic, and a pH. So we have metabolic alkalosis because of the alkalosis. We're on the alkalosis side of the equation. Okay? So, do we have compensation? Remember that's step 5 to see if we have compensation. And remember, compensation would mean that the other variable, this one here, PaCO2, that we don't have a slot for here, is in the opposite direction. So it would be over here. That did not happen. So here we do not have compensation. So basically, we would just call this metabolic alkalosis. And then the next thing you have to do is just remember what kind of patients would be in a metabolic alkalosis. So in other words, vomiting hydrogen, NG tubing hydrogen. Okay, so metabolic alkalosis is getting rid of too much acid. All right, very good. So I'm going to just see if I can get my eraser to work and get these guys out of here. All right, very good. It worked quite nicely. All right, so we're going to move on to the next practice. So let's just see what that says. Oh, okay. So actually we were going to, sorry, I guess I talk about metabolic alkalosis. So again, remember we can get it because of a loss of acid, and we do that by vomiting or by NG tube suction. Or we can get it from a gain of base. Remember, that was increased intake of bicarb. So somebody who's taking too many Tums, okay? And then also the treatment. So what do you do for a patient who's vomiting? We're going to give them an antiemetic to stop the vomiting and give them fluids, and that will help resolve. And again, what do you do with a patient who's got NG tube suction? We're going to give them IV fluids, either normal saline or lactated ringers. All right, so let's do another practice. And we're going to write down that we have a pH of 7.10, a PaCO2 of 25, a bicarb of 7, and a PaO2 of 95. All right, so we're going to move back over to the iPad and draw this out. And you feel free to draw it out on your paper as well, so that you get the same kind of experience with drawing these out. Okay, so this time we had a pH of 7.10. So obviously that is going to reside over here. It's less than 7.35. So C for 7.10. We have a PaCO2 of 25. So that's over here. It's less than 35 is 25. We have a bicarb of 7. That's less than 22. So that's over here. And we have a PaO2 of 95. So that's perfectly normal. Okay, perfect. All right, so again, where's our match? As you can see, our match is here. So again, we have a metabolic, because it's with bicarb and pH, we have a metabolic acidosis. And this time in step 5, we're looking at this opposite value, the one we hadn't dealt with yet, the PaCO2. Is it in the opposite lane? It is indeed. So we do have compensation. So here we have a metabolic acidosis. Now we know we have compensation, so now it's time to teach you whether we have a partial compensation or whether we have fully compensated. Okay, so the rule is super easy. If the pH has gone back to normal between 7.35 and 7.45, that's fully compensated. Okay, that's why we have this little number up here, this 7.40, and we'll do some more practice with that in a minute. But here, we don't have, the pH is not between 7.35 and 7.45, so we have compensation, and it's partial compensation. So here we have what we would call a partially compensated metabolic acidosis. All right? Pretty cool, eh? ABGs are super fun, I think. All right, so I'm just going to reshare the PowerPoint, and we're going to take a look at the reasons for that. So why would our patient have a metabolic acidosis? Remember? Why would our patient have a metabolic acidosis? Remember, there were a couple of reasons. One that you're going to have to know for this exam for sure is diabetic ketoacidosis. And I'm just going to reshare, and I know that I just stopped sharing, so I'm sorry about that. But I'm going to reshare the PowerPoint. Sorry that I have to keep going through the screen mirroring thing. It's just a pain in the butt, but we got to do it. Because I want you to see this 25 over here, alkalosis, and how that's partially compensated metabolic acidosis. So if you have your patient with DKA, all right, and that's diabetic ketoacidosis, they're trying to blow off CO2. So that's why we have a respiratory alkalosis. We have this compensation. So this compensation actually represents this, Kussmaul respirations. Yeah, cool, huh? You can see it on the ABG. Super cool. All right, we're going to go back to sharing the PowerPoint. And indeed, you can have the metabolic acidosis either by losing base, so you could have a severe diarrhea where you'd lose bicarb, and you would give fluids and Imodium to stop the diarrhea, fluids for the dehydration, the fluid volume deficit, and we give some potassium as well. Or we can get it by a gain of acids. And that's what happened here with our DKA. We have diabetic ketoacidosis. So what do we do for those patients? We give them insulin and fluids. And remember, they might actually have a hypokalemia as well, as the insulin opens up that sodium potassium pump. Okay, so it can also happen with your renal failure patients. It can happen with patients who have taken too many aspirin. They'll have a salicylate acidosis, and we'll give them activated charcoal for that. And it can happen in your shock and septic patients. Remember, those patients who have to switch to anaerobic metabolism. And for them, we give antibiotics if they're septic, and or for shock patients, we'll give them oxygen and fluids. All right, excellent. So now let's practice some more. So I'm going to write this down. So we have a pH of 7.42 and a PaCO2 of 18 and a bicarb of 11 and a PaO2 of 95. So let's do this one on the iPad as well. All right, so let me just use my little eraser and get rid of all this stuff that we wrote. All right, perfect. We're back to just our standard template. And so now, again, we had a pH of 7.42. All right, so this is where we're going to practice that use this 7.40. So 7.42 is between 7.40 and 7.45. So I'm just going to slap it up here, okay? 7.42. We have a PaCO2 of 18. That's over here because it's less than 35. We have a bicarb of 11. That's over here. And we have, again, a PaO2 of 95. So we're perfectly fine. We're oxygenating well. Okay, so now we have to look at our match. So again, we don't have two things in the right-hand column, but we do have something to the right of our magic number, the 7.40. So we're going to call those two the match. All right, so our patient basically has, because it's PaCO2, this is respiratory. Okay, so we have a respiratory alkalosis because it's to the right of the center towards the alkalosis side, this alkalosis. And we have some compensation, don't we? Because we have a value in the left. Now, are we fully compensated? The answer is yes, because our pH is back to normal. It's between 7.35 and 7.45. So here we have a fully compensated respiratory alkalosis. Okay, pretty cool. All right, and have the kidneys kicked into work? Has it been going on for a few days? Yes, because the kidneys have kicked into work. All right. All right, new share. We're going to go back to the PowerPoint. And we're going to say this is alveolar hyperventilation and a decrease in PaCO2. This can happen with your heart failure patients. It can happen with patients who have an ongoing fever or an anemia where they're hyperventilating or have increased respirations because of compensation. It can happen with patients who are septic. They basically start to have cardiac compromise, and so they start breathing rapidly to get to compensate for low cardiac output. Same with your heart failure patient, or it could be a patient with hysteria. Highly unlikely it's a patient with hysteria here though, because that would be acute. And remember, our kidneys had already compensated. So if you had to pick out of these three, which one probably is not the one, it would be the hysteria, because it would be hard to believe that somebody would be hysterical for 3 days on end. Okay. All right. So that's the one we just did. Sorry about that. And we're going to practice some more. So I'm going to write it down again. This time we have a pH of 7.30. We have a PaCO2 of 50, a bicarb of 23, and this time we have a PaO2 of 75%. All right, so we're going to switch to our iPad. And take a quick look at this one. Oops. All right, so we're back to our regular template, and we're going to plug in these numbers. So we have a pH of 7.30. That is less than 7.35, so it's going to go right here. And let me just put my eraser on there, and I just wanted to make that a different color. Okay, so 7.30. And then we have a PaCO2 of 50. That's here, greater than 45. And we have a bicarb of 23. And we have a PaO2 of 75%. Okay, so here is our match. So we have a respiratory acidosis. We do not have compensation because there's nothing in the alkaline section, nothing in here, right? So no compensation. But we have this thing that we need to deal with, okay? So this is hypoxemia. Different from hypoxia because emia means that it's in the blood. Okay, so it's in an arterial blood gas, so we have a hypoxemia. So here we have an uncompensated metabolic, I'm sorry, excuse me, that is not a metabolic. Sorry about that. Respiratory acidosis with hypoxemia. Okay? All right, perfect. So we're going to go take a look at what kind of patients would be in this state. So again, we have an uncompensated respiratory acidosis. So do you understand that that means the kidneys have not had a chance to kick in yet? So this is an acute finding. Okay, this just happened or has happened recently. The kidneys have not kicked in. We have no compensation by the kidneys. All right, so if we take a look at who's going to have this, this is going to be somebody that has CO2 retention. Maybe they have a depressed ventilation. So perhaps your patient who's on a PCA pump and is not breathing adequately, 12 to 20 breaths per minute. Maybe their respiratory rate's like 8. And basically this will lead to hypercapnia, which just basically means an excess PaCO2. And these patients are going to be really tired. That's why your PCA patients don't wake up and tell you that they're having trouble breathing, because the more the PaCO2 is retained, the CO2 is retained, the more that tired that they get. Okay, so what are we going to do? We're going to give these patients oxygen and we're going to correct the underlying problem. So if we're talking about our PCA patient, we're going to turn the PCA, we're going to probably take off the basal rate, which means the continuous rate, and just let them push the button. Okay. All right, let's practice some more. So we have a pH of 7.30, a PaO2 of 60, and a PaCO2 of 45. All right, so we don't have a bicarb level here, so we're just going to assume that the bicarb level is normal. All right, and I'm going to start the screen share with my iPad, and we'll draw this one out. All right, so in this one, we have a pH of 7.30. That's over here. And we have a PaCO2 of 45. That's right here. And we have a PaO2 of 60. All right, so let me tell you that this was the blood gas of one of my patients coming into the ER who had suffered a pneumothorax, okay? And it was, the patient was at home and it was like a spontaneous pneumothorax, so she was probably like a long-term smoker and basically a bleb burst. But she suffered a pneumothorax, which basically means that air was going into her chest and pushing her lung to the side. So she had lost the ability to oxygenate with one of the sides of her lungs. So she's going to go into, very quickly going to go into a respiratory acidosis, but the reason that the PaCO2 is still on the very end of normal is because it's so acute, all right? So basically right now what our patient has is a profound hypoxemia with an impending respiratory acidosis. Does that make sense? I think it's so cool what you can see on these ABGs. So when you go to clinical, I really want you to ask your professor if he or she could bring to post-conference some ABGs so that you can kind of start to think like, what do these mean and what's it mean for my patient? So they're pretty cool. All right, so I'm gonna go back to the PowerPoint and we'll see if I talk about this patient. I think I did. No, I already told you about the patient. All right, so now we're going to move on to kind of trying to differentiate what we think is happening to the patient without actually analyzing the blood gas. Okay, so this is another way that I can ask you exam questions, is to give you a patient and say, what do you think the blood gas is going to be? All right, so here we had a client who was recovering from surgery in the post-anesthesia care unit in the PACU. And the client's really difficult to arouse. And that's within about 2 hours following their surgery. So the nurse in the PACU has been giving morphine sulfate intravenously to the client for complaints of post-surgical pain. So the client's respiratory rate is 7 per minute, and he demonstrates shallow breathing. He's not responding to any stimuli, and the nurse assesses the patient's ABCs and orders ABGs stat. So what do you think that the patient's ABGs looked like? Remember again, this is your patient with an opioid or barbiturate or sedative overdose who has a respiratory rate of 7. So by now, you should be able to say, I really think that this patient probably has a respiratory acidosis and it's acute. So there probably will not be compensation by the kidneys, okay? So that's what I'm hoping that you can do. So let's take a look at the next slide and see what those ABGs were and see if we're right. So we had a pH of 7.15, a PaCO2 of 68, and a bicarb of 22. So moving back to our PowerPoint, or I'm sorry, I mean the iPad. We're gonna just do a quick look and see what those look like. All right, first thing I need to do here is get out my eraser. All right, so we have a pH of 7.15, so that's over here. And we have a PaCO2 of 68 and a bicarb of 22. And so we are right. Look at that. We have a respiratory acidosis. It is acute because there is no compensation. And you guessed it. All right, very good. All right, let's try another one. So we have an infant who's 3 weeks old, admitted to the ER, and the mother reports the infant has been irritable, difficult to breastfeed, and has had diarrhea for the past 4 days. All right. All right. So the infant's respiratory rate is elevated, and the fontanelles are sunken. And the emergency physician orders ABGs after addressing the ABCs. So the fact that the respiratory rate is elevated and that the fontanelles are sunken also leads you to the diagnosis of, hopefully you chose, fluid volume deficit. Okay, and that makes sense because your little infant has had diarrhea for 4 days. That's a long time for an infant to have diarrhea. So what do we suspect here? What do we suspect if your patient has had diarrhea for 4 days? Well, let's take a look at what happened. So here's our pH. Let's see if you were right. 7.37. Your PaCO2 is 29 and your bicarb is 17. And let's plug that into our iPad and see what we come up with. All right, we have a pH of 7.37. So that's right here. And we have a PaCO2 of 29. And we have a bicarb of 17. So remembering this number, 7.37, is on the acidotic side. It's on the left of our magical number, okay? So we have, here's the match. So we have a metabolic acidosis, and we definitely have compensation. And we are fully compensated because the pH is back to normal. So we have fully compensated metabolic acidosis. All right. And that makes sense that the PaCO2 is elevated because remember she had an elevated respiratory rate. So she was trying to compensate by blowing off CO2 for the metabolic acidosis. Okay? All right, very good. Moving on. Let's see if we can do another one. Here we have a client who's 5 days post-abdominal surgery and has an NG tube. And the nurse notes the NG tube is draining a large amount, 900 mLs in over 2 hours, of coffee ground secretions. Okay, so we call that coffee ground emesis. Okay, so that's old blood, old dried blood. We'll talk about that when we do our GI lectures. But basically, the client is not oriented to person, place, or time. And the nurse contacts the attending physician and stat ABGs are ordered. And this is what they say. What do you think is happening? Remember NG tube suction. So hopefully you said metabolic alkalosis, and I think that's what we'll find on our ABGs, but let's take a look and draw them out. 7.52 is our pH. PaCO2 is 35, and our bicarb is 29. All right, so let's draw those out. Okay, so we're back to our original thing, and 7.52, 35, and 29. All right, so our match is right here. So we have a metabolic alkalosis, which was our suspicion, and we do not have compensation, okay? So we have a metabolic alkalosis and uncompensated. That's how we say that, okay? Uncompensated metabolic alkalosis. So that's from NG tube suction. Okay, loss of acid. Loss of acid. Think about the stomach. Has stomach acid. Okay, perfect. I think we're almost done, so hang in there. All right, the client's admitted to the hospital and is being prepared for a craniotomy or brain surgery, and he's very anxious and very scared, and he begins to hyperventilate and he becomes very dizzy. So he loses consciousness, he gets himself worked up, he's in hysteria, and so you draw stat ABGs, and what do you think they're gonna show? Yeah, if you said respiratory alkalosis, you're right. But let's really make sure. Let's take a look on our iPad and see if this is the case. All right, so looking on our iPad, oops, I need to write these down first. So 7.57, 26, and 24. All right, so I'm gonna share the iPad. Okay, and our numbers are 7.57, so that's over here, 7.57, and 26, woo, 26, that's low, 26 and 24. All right, so we were right. We have a respiratory alkalosis. It's acute, it's happening right now. That's why there's no compensation over here. All right, so we have an uncompensated respiratory alkalosis. Okay. All right, I'm pretty sure we have just one more, or maybe two. So we have a 2-year-old admitted to the hospital with a diagnosis of asthma and respiratory distress syndrome. All right, so remember, asthma is a form of COPD. All right, so it's all falls into COPD, chronic lung limitations. So here, automatically, we think we probably have a respiratory acidosis. But let's see. The father of the infant reports to the nurse that he observed slight tremors and behavioral changes in the child over the past 3 days. That would be because of hypercapnia. Or a high PaCO2, which would happen in a respiratory acidosis. The attending physician orders routine ABGs following an assessment of ABCs, and the ABG results are, so I'm just going to write these down. We got 7.36, 69, and 36. And let's just see what we have. Okay. So 7.36 is right here. And 69 is right there. And 36 is all the way over here. So we have a respiratory acidosis that is compensated, and it is fully compensated because the pH is within normal limits. Okay, so we have here a fully compensated respiratory acidosis. Okay, perfect. We got it right. Hang with me. We're almost done. Let's see. I think this is the last one. Almost. Okay. All right, let's see. All right, we have a young woman who's drinking beer at a party, falls down and hits her head on the ground. A friend dials 911 because she's unconscious and she has depressed ventilations, shallow and slow respirations. There's your ticket right there. So you know exactly what she has now. Okay, so she has that. And so we think she has what primary acid-base imbalance? And if you said that she has respiratory acidosis, you are right, I'm pretty sure. And here we have an 11-year-old boy who's admitted to the hospital with vomiting, nausea, and overall weakness. What do we have if we have vomiting? Remember, and we have a low potassium here. We are going to have a metabolic alkalosis. An elderly gentleman is seen in the ER at a community hospital. He admits to taking too many aspirin. So he has salicylate. It's an acid. So he has a metabolic acidosis. Okay. A young man is found at the scene of an automobile accident in the state of emotional distress, hysteria, reports numbness and tingling in the fingertips, and feels dizzy. Okay. Respiratory rate is 34. We anticipate he's in a respiratory alkalosis, blowing off too much CO2. And that is it. I hope you enjoyed this ABG lecture. Let me know if you have any questions. Take care. Bye.